Postnatal period. So the puerperium covers the 6-week period following birth, during which time the various changes that occur during pregnancy revert to the non-pregnant state. And physiologically, the postpartum period begins with birth of the placenta and continues through to the involution of the uterus and return as other reproductive organs to a non-pregnant state. This is not the same pre-pregnant state the woman experienced prior to pregnancy, because pregnancy can have some lasting effects on a woman's body. Classically, the postpartum period is considered to last between 6 to 8 weeks. However, this time period is not precise and varies among women. Among breastfeeding women, the anatomy and physiology of the mammary glands will continue to be different than in a non-pregnant, non-lactating woman for the duration of lactation and beyond. A woman's ability to complete the important task of bonding and caring for her new infants, or in the case of stillbirth or other loss, the task of grieving and healing, will be affected to a significant degree by her physical well-being. Her physical well-being will also interfere the probability to her developing postpartum depression. It is crucial, therefore, that the midwife, nurses, physiotherapists possess an accurate understanding of normal postpartum anatomy and physiology and be vigilant for any signs of complications. Now I will tell you a few words about the postpartum homeostasis before I will start telling you about physiological changes. So, following placental separation and expulsion from the uterus, a series of events must immediately occur in order to ensure maternal hemostasis at the placental attachment site. This series of events begins prior to placental separation with oxytocin-induced contractions of the myometrium that cause a permanent and progressively increasingly shortening of muscle fibers. So I'm telling about this third stage of the delivery. In addition to promoting the separation of the placenta from the uterine wall, this shortening and retraction of muscle fibers compresses the maternal arteries that served as the vascular supply to the placenta. As the myometrium contracts, the uterine walls press against each other and may also promote hemostasis. Therefore, the mechanical compression caused by myometrial contractions remains the primary mechanism of hemostasis in the immediate postpartum period. However, a clotting response is initiated at the time of placental expulsion that will further contribute to hemostasis at the placental attachment site. Uterine atony during the first hour following delivery can lead to massive maternal hemorrhage, especially if the contractions are inadequate. During normal pregnancy, a series of changes in coagulation and fibrotic systems promote adequate uteroplacental circulation. During the postpartum period, some physiologic changes permit adequate coagulation at the placental attachment site following placental detachment. The changes help protect the woman from hemorrhage following birth. In brief, during pregnancy and particularly in the third trimester, the woman experiences an increase in a number of clotting factors. These factors are the 1st, 2nd, 7th, 8th, 9th, and 12th, a decrease in protein S levels, and a progressive fall in the activity of activated protein C as gestation advances. Postpartally, these clotting factors promote coagulation of the shed maternal vessels at the placental attachment site after the birth. However, while the clotting factors protect a woman from hemorrhage, they also predispose her to thromboembolic events. The relative proportions of coagulation factors appear to return to their non-pregnant state by 3 weeks postpartum, but certain clotting cofactors levels, such as protein S levels, may not return to normal levels until 8 weeks postpartum or later. And here the biggest changes occur in a pregnancy. One of the biggest changes occur in a cardiovascular system, and we know that the cardiovascular system reverts to normal during the first 2 weeks. The extra blood load on the head from extra volume of blood disappears by the 2nd week. And a series of significant and rapid cardiovascular changes occur immediately postpartally that include loss of blood, autotransfusion of 10 to 15% of blood volume secondary to removal of the low-pressure fetal placental unit, and mobilization of extracellular fluid back into circulation. These dramatic fluid shifts make the postpartum period a period of maternal cardiovascular instability and a time of increased risk of adverse outcomes, including pulmonary edema, cardiac failure, and death in women with pre-existing cardiac disease, hypertension, or preeclampsia. We know that in the first 10 to 15 minutes after the birth, maternal stroke volume and cardiac output are increased approximately 80% above pregnancy levels. Theoretically, this effect is hypothesized to be due to increased cardiac preload that results from autotransfusion of uteroplacental blood back into maternal systolic circulation and improved venous return with decompression of the vena cava secondary to removal of mechanical pressure from the gravity uterus. In the first postpartum hours, stroke volume and cardiac output remain elevated and heart rate decreases, but mean arterial blood pressure is unchanged. Mobilization of extracellular fluid back into circulation in the first few postpartum days also contributes to increased blood volume. This acute increase in blood volume helps compensate for the normal blood loss of parturition following the sudden increase in the cardiac output immediately after birth. Blood volume declines to pre-pregnant levels over a period of approximately 2 weeks. Normal return of cardiovascular function depends in a part on physiologic disruptions in the first week postpartum. Without normal excretion of the extracellular fluid into the intravascular system, there is an increased risk of pulmonary edema, particularly among women with cardiac disease or preeclampsia in a pregnancy. Also, the increase in stroke volume first during pregnancy and then during the postpartum period leads to a temporary increase in the size of the left atrium of heart. This physiologic ventricular hypertrophy resolves more slowly than the increase in stroke volume and cardiac output. Left ventricular size does not return to normal until approximately 6 months postpartum. The blood loss that occurs during birth causes a marked decrease in the red blood cell volume. In addition, a period of hemodilution arises in the first postpartum week due to the increase in plasma volume that occurs in interstitial fluid is mobilized. The loss of red blood cells combined with this hemodilution leads to a decrease in hemoglobin and hematocrit in the first postpartum week. A woman's hemoglobin and hematocrit gradually return over a 6 weeks period to a pre-pregnant value as plasma volumes and red blood cells production also return to normal. Okay, I The vaginal wall is instantly swollen, bluish, and pulling but rapidly regains its tone, although remaining phallic for 2 weeks. Perineal edema may persist for some days. We have to remember that during labor the maternal cervix becomes soft, dilated, and shortened. It may also be bruised and bleeding during this time. In the first few postpartum days, the cervix recontinues, and by the end of the first week, the endocervical canal has reappeared and the os usually is only approximately 1 cm dilated. The external cervical os usually does not return to its previous non-pregnant form with its dimple shape characteristic of most cervical in a null-parous woman, but rather takes the form of a slit. The cervical endothelium also undergoes remodeling during the postpartum period, which has been associated with regression of high-grade cervical intraepithelial lesions. The vagina is initially emendos and bruised after a vaginal birth and has lost in pre-pregnant tone and range. The vaginal length returned to approximately 3 to 4 weeks postpartum, but the pre-pregnant vaginal tone may never be completely restored. The vaginal epithelium is usually healed by 6 to 10 weeks of postpartum. Okay. After the delivery of the placenta, the uterus is at the size of 20-week pregnancy, but reduced in size on abdominal examination by 1 finger breadth each day, such on the 20th day it cannot be palpated. By the end of puerperium, it's only slightly larger than pregnancy. And this uterine involution is the process of uterine contractions, myometrial cell shrinkage, re-establishment of the endometrium through necrosis, and removal of the endometrium through sheathing of the gluteal tissue lochia, and regeneration of the endometrium. The process starts immediately after birth of the infant and takes approximately 6 weeks to complete. The uterus weighs approximately 1,000 grams after the birth, and the fundus can be palpated as a firm mass in the abdominal midline several centimeters below the umbilicus. In the first few days postpartum, the uterus lies in a slightly retrograde position that drapes over the sacral promontory and is easily palpable in the abdomen. As the uterus contracts further, it undergoes a rotation of 100 till 180 degrees along the axis of the internal os and assumes an upright position by postpartum day 7. But at the end of the first week, the uterus weighs approximately 500 grams and is still palpable above the symphysis pubis. By 2 weeks postpartum, the uterus weighs approximately 300 grams. At this point, it has typically taken on its non-pregnant anatomic position in the pelvis, which in most women is an inverted inclination, and it's no longer able to be palpated abdominally. Uterine contractions are not the only factor involved in involution of the uterus. The organ also loses mass because of decrease in placental hormones that trigger myometrial cells autolysis. The result is a marked decrease in the size rather than the number of myometrial cells. Approximately 90% of the excess cellular protein is broken down by proteolytic enzymes that are released by myometrial cells endometrial cells of uterine blood vessels, and macrophages. In early pregnancy, the uterine endometrium undergoes significant remodeling during implantation, the process known as the dual relation promotes the normal development of growth of the placenta and the embryo. The remodeled endometrium or dehiscua is divided into multiple layers or strata. Postpartally, the placenta separates at the spongy portion of layer known as the dehiscula basilis, most of which is sloughed off with the placenta or in the early postpartum period. In the second and third postpartum days, the remaining dehiscua becomes differentiated into two layers, identified as the superficial and basal layers. The superficial layer is formed through leukocyte invasion and protects the decimated endometrium from infection. Ultimately, this layer becomes necrotic and it's sloughed off. In contrast, the basal layer remains intact and gives rise to the new endometrium through proliferation of the remaining glandular and stromal tissue. By first week postpartum, the endometrial surface has become emphasized. By 2 to 3 weeks postpartum, the endometrium has regenerated and resembles a non-pregnant endometrium, excluding the placental implantation site. The remaining thrombosed vessels at the placental implantation site takes approximately 6 weeks to heal through an exfoliation process of sloughing infused and necrotic tissue, followed by a process of endometrial remodeling. For the first 3 days, lochia comprise mainly blood and remains of thromboplastic tissue. During days 3-12, the color is reddish-brown, but then changes into yellow. Occasionally, lochia may become red again for a few days due to thrombi at the end of vessels breaking. And the postpartum vaginal discharge that begins immediately at birth and continues for approximately 4 to 8 weeks is termed lochia. The median total duration of lochia is 33 days. Lochia fada is described as lochia rubra, lochia seriosa, and lochia alba based on its changing color. The color results from the changing composition of the tissue that is sloughed and expelled in the postpartum endometrial restoration process. In Italy, the lochia consists primarily of blood. As a result, lochia rubra is red or brownish, red in color. As the uterine bleeding decreases at approximately 3 to 5 days postpartum, leukocytes infiltration occurs and the placental implantation site undergoes exfoliation. At this point, the discharge contains some blood. But primarily would exudate and leukocytes, and therefore lochia seriosa is a pinkish-brown color. The median duration of lochia seriosa is 22 days. Some women will experience a transient increase in bleeding 7 to 14 days postpartum, secondary to sloughing of the placental eschar or scab at the placental site. Toward the end of the process of uterine involution, the endometrium has been primarily restored. Lochia alba is composed predominantly of leukocytes and some reticular cells, and it's white or yellowish white in color. Here you see the picture how the color of lochia is changing, and according to the percentage of women, we see that at the very beginning of the postpartum period, lochia in 80% of women is bright red, Later it is red and brown, later becomes pink, pale pink, cream, and variable. It's quite interesting. Just a second. It's quite interesting that most of women after 2 weeks the color is changing into yellow. Before we start talking about common puerperal problems, I think it makes sense to tell you a few words about endocrine changes that occur during the postpartum. So, an abrupt drop in the blood fat levels of multiple hormones, including human placental lactogen, human chronotropic gonadotropin, estrogen, and progesterone, occurs when the placenta is expelled. The abrupt drop in plasma levels of these hormones in turn set in motion a series of endocrine alterations, including changes in glucose and lipid metabolism and the inhibition of lactogenesis. With decreasing levels of circulating estrogen, the thyroid binding globulin level, which was elevated in pregnancy, also drops. The change in turn leads to less production of triiodothyronine and thyrotroin and a gradual return to non-pregnant thyroid function. However, the incidence of thyroid dysfunction is more common in the postpartum period than in other times during woman's life. Postpartum thyroid dysfunction, including postpartum thyroiditis, is often transient. Postpartum thyroiditis, a thyroid disorder that manifests during the first postpartum year, is thought to be an autoimmune disorder that is unmasked in the postpartum period due to the rebound in immunoglobulinic function that follows pregnancy. It is often postulated that the marked changes in the maternal hormonal milieu in the postpartum period may be the cause of postpartum mood disorders, including postpartum depression. Studies that had evaluated the link between hormonal changes and the development of depression have yielded contradictory results and in general have not found a consistent link between hormone levels and postpartum depression. And also the significant methodological difficulties arise when trying to identify a causal link between any given biologic factor and the development of mood disorders, particularly at a time of significant change in the physiologic and physiosocial systems. However, lack of evidence does not necessarily mean that not much link exists. Also, currently, hormone levels cannot be used to effectively predict the development of postpartum mood disorders or to determine need for treatment. What are the common puerperal problems? If the perineum has been damaged and repaired, it may cause considerable pain, requiring analgesia, and women may prefer to sit on a rubber ring. If the perineum is painful, it's important to check the sutures and check for any signs of infection. Occasionally, sutures may need to be removed. Mictulation, retention of urine can occur, possible secondary to pudendal nerve bruising, and can occasionally require catheterization. Approximately 50% of women will develop some urinary incontinence after the labor, and this usually takes the form of stress incontinence. This may persist after the pregnancy. Pelvic floor exercises should be taught and encouraged. Bowel problems. Constipation may be a problem for a short time, and stool softeners may be useful. Hemorrhoids may be more painful after the birth than before. These can occasionally appear for the first time perinatally, and these normally disappear within a few weeks. Mastitis. So this may be due to the failure to express milk from one part of the breast. It can be treated by ensuring all milk is expressed and with cold compresses. It may be complicated by infection with Staphylococcus aureus and require treatment with fluxetocilin. Very occasionally, a breast abscess develops and requires incision and drainage. Backache. This may persist after the birth and affects approximately a quarter of women. Pain may be considerable and last for several months. Physiological problems partially associated with these endocrine changes, as I mentioned before. So we have third day blues. On days 3-5, a large proportion of women become temporarily sad and emotional. So this is the time also when first breastfeeding problems occur, and also 3 days after the labor, woman simply starts realizing that their life has changed, and for some of them, finding themselves in a totally new situation is difficult. And also the changes occur in neonate. These changes are associated with the adaptation to the environment. That's why most of the babies on these days from 3-5 days, they are very they can crying a lot. They are not calm, and we need to know that during that time we have to support as much as we can our patient. What's more, we have to pay attention on the patients who have in their history some depression or another psychological psycho problems, and that's why it's very important if we work with this kind of patient in this time when they are 3-5 days after the delivery, that we need to pay attention on how the woman behaves, how she reacts on the informations that we give her, how she take after the baby, and also we have to observe her partner if the partner is visiting her. It's worth to tell him that during these 3-5 days, in these days, lady may have simply a hard time, and he also has to support her, because family support is the most important here. You know, some nowadays we have like a false view of motherhood, and for some women, like meeting with the reality, it's hard. And also the problems with the breastfeeding occurring there, which occur there, may simply make these general problems stronger. Approximately 10% of women suffer from postnatal depression, which may present at any time during the first year after the delivery. The precise cause of this is unknown and may involve hormonal changes, As I told you, reaction to excitement of childbirth and doubts by the mother about her ability to care for the child. Management consists of reassuring the mother and explaining what is happening. Maternal activity. The mother should start walking about as soon as possible, go to the toilet when necessary, and rest when she needs to. She may prefer to stay in bed for the first 24 hours or longer if she has an extensive perineal repair. This is an important time for the woman to be encouraged to breastfeed and learn to care for her infant. Uterine contractions continue after birth, and some women suffer after pains, particularly when they breastfeeding their babies, and they may require analgesics. From my experience, I will tell you that those girls who are having their second and the next babies, they have stronger uterine contractions, maybe not stronger but more painful, since they still have a wound on the uterus, and after the first delivery. So these girls who are mummies for the next time, that postpartum time is simply harder for them. And normally here in Poland, after vaginal delivery, lady stays in bed for few hours. We say that after 8 hours she may get up, and we help her with taking care after her baby, but also what's important that after cesarean section they of course stay in bed longer, since of anesthetics that was used during the operation. And if you enter the postpartum ward at hospital, you would notice which woman had a normal vaginal delivery and who had a cesarean. Why? Because these girls who had a cesarean, they simply, for them, that postpartum period is very, very hard, very, very painful, and simply for them it's hard to take after the baby because they are in pain. And those girls who had normal vaginal delivery, after a few hours they are simply waking up, they are taking care of the babies, they are active, they are not they are tired, but they are in a better state than health status than those girls after the cesarean. What's breastfeeding? So breastfeeding boosts the baby's immune system, the reduction of autoimmune disorders later in life, reducing risk of cold death, reducing gastrointestinal problems, promoting bonding between the mother and the baby, and we need to encourage women during the first days to breastfeed their babies. And we know also that the breast engorgement may cause a lot of discomfort, but it's usually relieved by a good bra support and analgesia. And we know that new mothers should avoid exercises that cause a bearing down on their pelvic floor, traditional abdominal exercises and high-impact exercises until care control, pelvic floor strength and bladder control has been regained. Omit or modify exercises that require fast or lateral movements, changes of the direction, jumps and extremes of joint positions until joint strength and stability has been restored. Avoid all activities that cause discomfort, particularly prone exercises when breastfeeding or heavy low-hair bleeding. What are the recommended postnatal exercises? So walking, swimming, aqua aerobic, yoga, pilates, low impact aerobic workouts, light wearing training, and cycling. The program objectives should include pelvic floor exercises. Muscles of the tongue needed to be retrained to effectively stabilize the spine, restore hip stability, strength and flexibility, postural strengthening, particularly upper and lower back, slowly resume aerobic exercise and exercise for all major muscle groups. Abdominal exercises. Initial focus should be on activation and straightening. Abdominal muscles need to be strengthened to resume maximum functionality and provide optimal stability and mobility to the gut. Abdominal exercises are most effective when performed several times throughout the day rather than at one time per day or once per week. The more consistently they are performed, the more body awareness is regained, which promotes faster, more effective abdominal healing and straightening. Traditional abdominal exercises are not appropriate if abdominal separation or diastasis recti has occurred. We should avoid crunches and plank type exercises because of abdominal breach. Exercise selection is crucial because certain exercises can cause and or exaggerate abdominal separation. Here very important practical advice. Incorporating baby may make exercise more convenient and enjoyable, however when using baby as a weight technique is often compressed, reducing the benefits of the exercise and increasing the risk to mom and baby. Aim for stress relieving, not stress provoking. Use correct technique during daily tasks such as carrying baby, feeding, wearing a baby carrier and pushing a pram. The focus should be on the varied benefits of exercise, as weight loss may not be repeated. And not for every woman the postpartum period looks like that. This is like a false view of postpartum period. And here I have information about first postpartum visit for a baby. So here very important is history taking. So we need to ask if breastfeeding has been interrelated. We need to inquire whether the baby has passed urine and meconium. And we have to elect any problems in a newborn. We have to refer to the specialist if the baby is not feeding well, if the baby has cold to touch or fever, baby is lethargic or has convulsions, difficulty in breathing occurs. Also, during the first visit for a baby, we have to do the examination of a newborn. We have to check if the baby cries and it's active, and we have to refer to the specialist if the baby is crying, lethargic or unconscious. Chest in drawing, we have to consult it if there is soft chest in drawing is a sign of pneumonia. When respiration is lower than 30 and higher than 60 breaths per minute. We have to check the central cyanosis and the bluish discoloration of tongue and lips. If it occurs, we have to consult it. And the temperature, if the temperature is lower than 35,5 degrees or higher than 37,4 degrees. We have to also check the baby's how the baby is eating, and here you have the picture which shows you the baby who is well attached to the breast and baby who is poorly attached to the breast. And here you see like the mouth is touching totally the nipple. Here you won't see it. I hope you see that there is like a free space between babies and mommy's nipple. We have to check if the chin touching the breast and the breast, and we have to check if the mouth are wide open and lower lip than outward. More areola visible above than below the mouth. Breastfeeding effects of poor attachment, pain and damage to nipples, leading to sore nipples. Breast is not emptied completely, resulting in breast engorgement. Poor milk supply, baby is not satisfied. Poor weight gain of a baby. Counsel mother on where and when to take a baby for immunization, because we have to discuss the immunization of a newborn too. During the second and third visit of a mother, we have to history taking. So as on the first visit, in addition, ask for history of continued bleeding, fall, discharge, swelling or tenderness or blast, feeling unhappy or crying easily. And the examination is the same as during the first visit, and management and consulting same as on the first visit. Also, if we do the visit, the third visit, the first thing is history taking, which is the same as the first visit, and management and consulting. So in addition to consulting in first visit, advise the mother to exclusively breastfeed for 6 months, to wear at a wean at 6 months. Fourth visit for a mother, and again we have to do history taking, and also we need during the first visit, we pay attention on the vaginal bleeding, if it stops or not, and we have to ask about the menstrual cycle, if it is back or not, and we have to ask about any problems that occur during with breastfeeding and any other complaints. And examination is similar. We have to tell her about the diet and the rest. We have to emphasize importance of nutrition as a second and third visit, and contraception, emphasize importance of using contraceptive methods, post-bracing and limiting family size. The key message for postpartum care mother. So make at least 4 postpartum visits for timely recognition of complications like sepsis, postpartum hemorrhage. Advise mother on nutrition, advise mother on rest, hygiene, breastfeeding and contraception, and inform her about the newborn. So screen for danger signs in newborn, advise the mother to keep the baby warm, take care of umbilicus, skin and eyes, give exclusive breast feeds, ensure correct positioning attachment to the breast. And if we talk about breastfeeding, I think it's worth to tell you a few words about weight loss in a postpartum period, since many patients ask about that. So weight loss following pregnancy is a common concern for women. Aside from the immediate weight loss that occurs directly related to the birth of the baby, explosion of the placenta, and loss of a fluid in the first postpartum week, the physiology of weight loss, which is outside the scope of this, does not appear to differ in the postpartum period from the physiology of weight loss on other types in a woman's life. And also the rate and amount of weight loss in the postpartum period seem to be determined by the same factors that determine weight loss at any point in a woman's life, including existing weight, BMI, diet, age, and activity level. Furthermore, studies indicate that pregnancy weight retention is not a significant determinant of excessive weight. A study of 7,000 women who were followed from the beginning of the non-pregnancy to beginning of the next pregnancy found the average increase in weight between the first pregnancy and the next was 3,4 kilograms. In recognition that humans tend to gain weight as they get older, additional studies that controlled for age found an increase of only 0,3 to 0,5 kilograms between pregnancies. And these findings suggest that interventions to reduce rates of maternal obesity should focus not only on the loss of weight gained in pregnancy, but also on primary prevention of obesity and weight management at a preconceptional visit. And we have to remember that the postpartum period is a time of remarkable and rapid physiologic adjustment, and knowledge of postpartum physiology is necessary to determine the difference between normal and abnormal progression during the period. Although the vast majority of women in the postpartum period have a normal course, it's important to teach all women about signs of danger and worrisome symptoms in the postpartum period. Finally, despite the relatively rapid change from the physiology of pregnancy to a non-pregnant physiologic state, it's important to remember and remind the woman that it's quite normal for her not to feel completely back to herself during the weeks and even months following the birth of a newborn. The postpartum period is a profound role transition and life-changing event that cannot be described via review of anatomic and physiological changes. Okay. Steps for transfer and reveal of a baby. Preparation. Explain reason for transferring baby to higher facility. If possible, transfer the mother with a baby so that she can feed the baby. A healthcare worker should accompany baby. Ask relative to accompany baby and mother. Communication. Fill up a refill from baby's essential information and send it with the baby. If it's possible, contact healthcare facility in advance. Care during transfer. Keep baby in skin-to-skin contact with mother. If not possible, keep baby dressed and cover. Ensure that baby receives, feeds. If baby gasping at respiratory rate lower than 30 breaths per minute, resuscitable baby using bag and mask. Okay, and now as a summary, a few words about these adaptations that occur in a postpartum period. So, if we talk about the perinatal and abdominal musculature, so the postpartum change is that the ligaments and muscle are relaxed, so the abdominal wall remains soft and flaccid in the immediate postpartum. Separation of the rectus muscles, diastasis recti abdominis may be present. Muscles and associated tissues that were stretched during childbirth gradually regain tone. And we have to remember that the recovery of abdominal muscular tone and resolution of the stasis recti abdominis are somewhat related to activity and exercise. And in skin and hair. So hyperpigmentation, including linea nigra and melasma, strina gravidarum, and other skin changes of pregnancy will fade or regress. With return of estrogen levels to non-pregnant levels, hair growth slows and follicytes enter into a hair shedding phase, which results in a period of alopecia or postpartum telogen effluvium. And also what we know that demand for nutrition and hormone levels drop abruptly. Maternal metabolism of nutrition begins to return to normal. Maternal insulin resistance seen during pregnancy begins to resolve so shortly after removal of the placenta. We have to remember that FSH and LH levels are very low, and prolactin and oxytocin they fall to normal non-pregnant values from 2 weeks if there is no lactation. And just a summary, to tell you a short summary, that the postpartum period is a time of a transition for women. The end of pregnancy initiates physiological changes as many body systems return to their non-pregnant states. The uterus involves cardiac output and blood volume decrease, and estrogen and progesterone levels drop. In women who choose to breastfeed, lactogenesis begins and lactation may continue for months or years. The postpartum period is such much more than just the physiological changes. It transforms the social and emotional context for the woman and her family. Okay. Okay, and of course, some common discomforts occur in a pregnancy, in a postpartum period, like hemorrhoids, breast enlargement, excessive perspiration, also some pain, stool problems with stool, perineal pain, and during every visit we need to help women to overcome these problems. Even back pain, which occur in a pregnancy, may occur in a postpartum period, and it can be very, very strong. So we, the medical staff, we have to remember that we need to do our best to help the patient.